interest in total knee replacement surgery. I use a minimally invasive technique which provides for a much more rapid return to function and a minimal amount of discomfort after surgery. This tape is prepared to answer a few of the very commonly asked questions about knee replacement surgery. Certainly this tape does not cover every question, and if you have other questions after this tape concludes, please feel free to ask. The first issue is, what really is a knee replacement? The concept goes back to what is arthritis. The bones in the knee have a smooth cushioning covering on them in a normal situation that's called cartilage. Arthritis is the loss of that cartilage, and so instead of having two smooth surfaces rubbing, you have two rough surfaces rubbing that resemble sandpaper on sandpaper instead of ice on ice. And this situation hurts. The concept of a knee replacement surgery is that the ends of the bone, not the entire bone, just the ends of the bone are cut off and shaped to fit a metal or metal and plastic combination that fits the same shape. The shape of the metal is very similar to what the bone originally was. But of course there are no nerves in the piece of metal, and so the replacement doesn't hurt. This usually provides a great deal of relief and a great deal of improvement in function. Overall, 90 to 95% of people will have a good or an excellent result after knee replacement surgery with few complications. Probably the first or second most commonly asked question, though, is when can I drive after the surgery? This is a very complicated question. There are probably many people out there right now driving that have no business being on the road. There is not a good test or measure for what truly is safe to drive. There are basic rules and regulations. You have to know the rules of the road to be able to operate the vehicle and such. But driving safety really involves responding appropriately to emergencies. Emergencies happen close to home, and so it isn't a question of just driving to the corner store. It's a question of driving at all. The emergency is every bit as likely to happen on the way to the store as it is on the way to California. Now, when you add the quotient of surgery, or the question of surgery, into the whole equation, it becomes a much more complicated equation. The bottom line here is that you as a patient, I hope, are a responsible adult. If you understand that my concern is your ability to handle the emergency, then when you can honestly say that you're not going to think twice about your new hip or your new knee after your surgery, if there's an emergency, then you can go ahead and drive. If there's any question, I don't want you getting behind the wheel in the first place. Many people ask what materials are used to make up the total knee replacement. There are many different materials that are used. The femoral component, or the top of the knee, is made out of cobalt chromium alloy. The tibial component is actually two pieces. One is a titanium alloy tray, and then a spacer that's made out of an ultra-high molecular weight polyethylene, which is a fancy plastic. I also resurfaced the underside of the kneecap with a patella, and that's a plastic piece. The next question that follows is frequently, how long will this joint last? Well, with the previous generation of implants and previous generations of plastics, the knee replacement would last 10 to 15 years. If one really believes all of the bench data that's come out about the new plastics, we expect knee replacement to last 30 years. I don't think anybody should be quite that bold, but I think it's reasonably safe to say that the knee replacement should last 15 to 20 years. Part of the reason for routine follow-up every so many years after the knee replacement is, one, look for signs of wear, and two, it might be possible to intervene when the intervention is simple, as opposed to wait until such time as it's very difficult to reconstruct. These are parts of a total knee replacement. As you can see, they come in different sizes, and there are also several different parts. The two parts here are the femoral component, and this goes on the end of the bone of the femur, or the top of the knee. And so the process of doing the knee replacement involves shaping the end of the bone to look like this, so this will then fit on and be a new surface where the old one is worn out. Of course, they come in different sizes, this one being a little bit smaller than that one over there. This here is a patellar surface. It fits on the underneath side of the kneecap, and it fits then when the knee is functioning here so that plastic rubs on metal and the bone doesn't touch it. These last two parts are the tibial tray and the spacer. The top of the tibia is cut off flat, and then a small indentation made to fit the shape of the bottom of this piece here. And that's cemented down, and then on top of that fits a plastic liner. Now it locks in. I'm not going to lock it in here. But that locks in, and then the whole knee goes together like so. So the motion is here. Do that from the side too. The motion is here. And again, metal on plastic, no nerves, gets rid of the pain of the arthritis. Now, some people, I've also discussed with them a partial knee replacement versus the total knee replacement. The knee itself has three different parts or compartments. This is a part is where one bone touches another bone. There's a part on the inside of the knee, a part on the outside of the knee, and a part in the front of the knee where the knee cap touches the femur or the thigh bone. Now, in most arthritic patients, two or more of these compartments are relatively arthritic. In some patients, somewhere between 10 and 20% of patients, only one of these three compartments is arthritic and the other two are really pretty healthy. If that's the case, why should I cut out two healthy compartments to replace one that's sick? There are instead partial replacements, replacing only 1/3 of the knee, replacing only the part that's arthritic, leaving the rest of the healthy knee intact. Now, there are advantages and disadvantages to this approach. The partial knee replacement will generally get a little bit better range of motion than the total knee replacement. The rehabilitation is easier. Now, the difference is getting smaller and smaller all the time with the minimally invasive techniques, but there still is a measurable difference. And many people say that the partial knee replacement feels more natural and more like their own knee. Now, the disadvantage, though, is one can still develop arthritis in the other parts of the knee. Just as if you have a cavity filled on one side of your mouth, you can still get a cavity and a tooth on the other side. If I replace part of the knee, the arthritis in the other parts can develop to the point where they cause symptoms later on down the road. Now, that would potentially necessitate a conversion to a total knee replacement, which is a little bit larger procedure than doing the total knee replacement initially. However, most people who have unicompartmental replacements 10 or 15 years down the line still have their unicompartmental replacements, and in several studies more than 90% of them have not been converted to total knee replacements. Those are pretty good odds, I think. Now, the unicompartmental replacement is a little bit different. It's roughly 1/3 of the total knee, replacing on the femur only one side, there being an inside, an outside, and a top. This replaces only the one side. And then the tibial tray, this one has its plastic already locked in, fits in this way here. So the unicompartmental replacement fits together this way, as seen from the side, like so. Many people will ask how much pain they'll have after the surgery. Well, everybody is different, and while some patients have no pain, most patients have some. What most patients will tell you, though, is the discomfort that they have is distinctly different from the pain of the arthritis. The surgical pain is both better covered by the medication that's given and also fades with time. And it seems to be of a character that most people can tell that it's going to fade. And during the first several weeks, it's very important that you do the exercises that are prescribed. And if you need to take the medicine, take it. It's there for a reason. Don't be a hero. Take the medicine if you need it and do the exercises. Getting the motion early on is very important. Later on, we can worry about getting people off pain medication. It's extraordinarily unusual to make an addict in this situation. If you give a good pain medication, when there is a legitimate source of discomfort, you don't get addicted. So please don't worry about that. Take the medicine if you need it and do the exercises. The surgery itself takes between an hour and a half and 2 hours. But that's not the time that your family will be waiting. In addition to that hour and a half or 2 hours, there will be at least 30 to 45 minutes of setup, getting the patient into the room, appropriately anesthetized, positioned, prepped and draped, and then the hour and a half or 2 hour clock starts. And so please tell your family that there will be a minimum of 2.5 hours, more likely close to 3 hours from the time they say goodbye to you in the holding area to the time that I come out and talk to them about how everything went. The hospital stay is usually 2 or 3 days after the surgery. The day of the surgery doesn't count in this. And most people are able to go directly home. Now, as far as discharge plans are concerned, most approaches to knee replacement and most surgeons will plan on sending most of their patients to a rehabilitation hospital. That's not what I do. Most of my patients are well enough and functional enough to go directly home. But I don't have a cookbook for this. I don't say people will go home after a certain number of days. I see after the surgery how each individual patient responds, what their level of function might be, and what their needs are. I'll give you 2 examples. One patient might have a physical therapist in the family, have a single-story house, and have relatives willing and able to take time to help out. That patient will probably go home pretty quickly. At the same time, I take care of a few elderly patients who live by themselves, have 30 steps to their front door, and have no one to drive them anywhere. They can't go home as quickly. And most people fit somewhere between these 2 extremes. And so after the surgery, we make a determination about what fits each individual patient best. Everybody gets therapy, just not everybody gets therapy at a rehabilitation center. In most cases, the ideal situation is to have the patient go directly home and then to outpatient therapy. The outpatient therapists, on average, are better therapists than are the home health therapists. And also, if you do therapy in their location, they have all of their equipment as opposed to that portion which the therapist might be able to carry to your home. But again, I'm going to emphasize that this is not a cookbook. Everybody gets what fits them best and what is most appropriate for them after the surgery. People will also ask, what are the risks of knee replacement surgery? Well, every surgery has its risks, just like every activity has its risks. And just like crossing the street, if you look where you're going, you're not likely to get into trouble. Major risks of any surgical procedure involve infection, bleeding, need for further surgery, and failure to achieve the goals desired. All of these are very low percentages, so that again, where I started, 90 to 95% of people have good or excellent results, and very few people need further surgery. One of the more important questions, of course, is what constitutes minimally invasive surgery. Here I'm going to have you watch a short presentation by American Health Front on this topic. They asked me to talk about minimally invasive surgery. Now, while this particular presentation talks more about hips than it does knees, the concepts are the same. In a minimally invasive knee replacement, I don't make it necessarily a 2-inch incision. The incisions are 4 to 6 inches instead of 8 to 12. But what matters in the recovery is how the tissue is handled underneath. And that concept, I think, comes across in this presentation.
The American Health Front is a presentation of Medical Media Group and the following physicians and healthcare organizations.
Today on the American Health Front, discover a new minimally invasive technique for total hip replacement, which uses only 2 incisions. We'll learn how patients with low back pain and leg pain can get relief with a less invasive treatment that's similar to having an injection. And come with us as we show you how advances in dentistry make it possible to change a smile like never before. Hello everyone, I'm Ernie Bjorkman and welcome to the American Health Front. The purpose of our program is to educate and inform you, the viewer, about treatment options now available in the ever-changing world of medicine. This is a special San Antonio edition of American Health Front. Our staff has teamed up with some of the area's finest physicians and healthcare facilities to explore the fascinating frontiers of today's healthcare, with reports on new techniques and technologies that could really change your life. So stay with us, because there is nothing more important than your health. An important goal for many people is to remain active long into their senior years. Thanks to developments in product technology and surgical techniques in orthopedic surgery, that goal is now often attainable. We take you to the office of orthopedic surgeon Dr. Adam Harris to learn about the new Zimmer, minimally invasive technique for total hip replacement.
The natural hip is a ball and socket joint. The ends of the bone are covered with a smooth, shock-absorbing surface known as cartilage. The arthritic hip has lost that cartilage and the surfaces resemble sandpaper. An artificial hip will replace both of the surfaces with bright, shiny, new, and now smooth surfaces.
About a year and a half ago, I developed severe pain in both hips, but the right hip was worse than the left, and it gradually got worse. I'm an ER physician, and got so bad that I could hardly go to a code because it hurt every time I took a step or when I'd stand on it.
When painful and debilitating joint disease of the hip is unresponsive to standard treatments, total hip replacement surgery may be your best option.
Traditional hip replacement surgery involves detaching or cutting into muscles in order to gain access to the joint. Then the surgeon must repair that damage on the way out. A lot of the pain after the surgery seems to come from either the damage done to the muscle or from the muscular tension on the repair.
Dr. Harris offers patients breakthrough procedures, which are minimally invasive joint replacements. Dr. Harris is the first orthopedic surgeon in South Texas to perform the Zimmer MIS 2-incision total hip replacement, and the first in San Antonio to perform the quadriceps sparing total knee replacement. Dr. Harris will now discuss the total hip replacement procedure.
Think about Venetian blinds. If the blinds are closed, it's very difficult to see out of the window. But you can put your fingers into the Venetian blinds, spread them apart, and see quite easily. Then when you take your fingers out, the blinds fall back to their natural position undamaged. This surgery does very much the same thing with muscles. The surgery is done between the muscles or between the fibers of the muscle so that when the instruments are removed, there's no damage to repair. I also apply the same minimally invasive concepts to knee replacement surgery with very similar results.
With this new technique, patients experience reduced recovery time and a rapid rehabilitation period. Let's learn more about the benefits.
Many patients will wake up from the surgery with less pain than they had before the surgery. Traditional hip replacement, on the other hand, will require 4 days or more in the hospital and then usually a week or more stay in a rehabilitation facility. Crutches or walker may be needed for 6 weeks or more. With this surgery, the average stay is less than 2 nights, and people under 80 will almost always go directly home. Crutches or a walker might be used only for a few days.
I had a hip replacement, and I've been very happy since then. I've been able to walk without pain and to do anything I want. In fact, I went back to riding a bicycle within a week afterwards and went back to work in a week.
This San Antonio edition of American Health Front is a production of Medical Media Group and 2010 Productions.
Another issue with regard to minimally invasive total knee replacement has to do with the placement of the incision. I refer sometimes to the fact that I go in from the side. What I mean by this is that I slip underneath the muscles of the quadriceps or the muscles of the thigh from the side. The incision itself is still pretty much in the front of the knee. It's just a little bit towards the inside, at the inside border of the kneecap on average. And this incision, just displaced a little bit from the standard, allows me to get to where I need to go to get underneath the muscles, getting underneath the muscles from the side. Again, it's a pleasure to assist in your health care. I'll be back in the room in a few minutes to answer any questions which remain. Thank you very much.